I'm going to just provide a quick introduction of just an opening. I'm with the Chronic Disease Prevention Council. My name is Laurel McCloskey, and one of our work groups is the Heart Disease and Stroke Work Group that is putting on this Lunch and Learn series. Welcome. And we have 2 additional Lunch and Learns coming up. The next one is next week. It's actually on a Thursday instead of the Wednesday. This is session 3, and it's titled Living with Disability After a Stroke. So it's going to look at common disabilities after a stroke, secondary stroke prevention, and lifestyle modifications after a stroke. So get that in your calendar and feel free to join. You can register as well, and it's from noon to 1 p.m. And then session 4 is a stroke survivor and caregiver panel. And that is back to a Wednesday. So our regular Wednesdays from noon to 1 p.m. And you're going to be able to hear from a diverse panel about survivors and caregivers. And this is session 2. We had an additional one, session 1, that will be on our website to the recording if you'd like to access it. And this is about acute stroke care, what to expect. And we're going to talk about hear from a stroke patient of a panel of stroke team members, what happens during a stroke. It's going to be moderated by the great Dr. Jessica Richardson, who's part of the stroke series. And we're going to hear from Shana Zink. She's an emergency nurse for over 20 years and the stroke coordinator for Presbyterian Hospital. So welcome, everyone. We're grateful to have you here. Please drop questions in the chat. Sophie's on, Devana, Molly, and I, we're the CDPC team. We're kind of in the background to help. But this is really the amazing efforts of the Heart Disease and Stroke Work Group and Dr. Richardson. We did this during the pandemic, probably a year and a half ago, and we just wanted to continue this conversation as there's not substantial resources for stroke survivors and caregivers in New Mexico. We want to engage the community and make an impact on this. So I know it's a big deal, and we all know people have had strokes, and the resources need to be more available. And we're here to help it become part of our awareness and part of the momentum of our work. So I'll hand it over to Dr. Richardson. Thank you.
Great, thank you so much. We're all happy to be here. And before we do get started with our panel, I just first wanted to thank all of the folks that are involved in the panel today, especially those that are, working in the hospital, especially during COVID. And even though we're out of COVID, we're not really out of COVID. They're busier than ever, and their time is so very valuable. And we are just really, really appreciative that you're taking this time to demystify the process of, once you're admitted with a stroke, of what happens. So I'm actually going to turn over to Shana. She's going to get us started to talk about why is stroke an emergency, what happens from her viewpoint as an emergency nurse and a stroke coordinator. So take it away.
Good morning, everybody. I'm happy to be here and talk about stroke care. I think everybody on this panel is pretty passionate about that and making sure that our stroke patients, at least in the hospital setting and afterwards, are getting the best care and returning to the highest quality of life possible. Which is really the focus of stroke care. So I just wanted to start off by talking about why stroke is an emergency, and then what can be expected during the initial care for a stroke patient. So stroke, as we all know, is a leading cause of serious long-term disability. But I was surprised to learn recently that it occurs every 40 seconds in the United States. Someone is experiencing a stroke. A stroke is simply explained as the inability of oxygen to reach the brain, but it's not simple. It's, without oxygen, irreversible brain damage occurs immediately. In just 1 minute, if untreated, a person can lose 1.9 million neurons or brain cells and 7 miles of nerve fibers. That's just astonishing when we think about how complex the brain is. And if that's occurring every minute, how critical it is for patients to get to stroke care as quickly as possible. And we also know that reducing that interval between when symptoms start and patients receive care results in the best outcome and minimizing disability and the potential for permanent disability to an individual, and returning to a quality of life that is acceptable for a patient. So most strokes, approximately 87%, are due to a blood clot that decreases blood flow to or within the brain, but it can also be caused by bleeding within the brain. And both the type of stroke and location within the brain determine the type of care that someone can receive. They're equally time sensitive. Back to that earlier statement about time really is brain tissue, because we're losing a lot of neurons every minute. So certain factors influence the risk of someone experiencing a stroke. That was what the webinar was focused on last week, and reducing risk factors. So I encourage you to take a listen to that one if that's something that you're interested in as well. Early recognition is key for seeking stroke care. So getting education out about the signs of a stroke and identifying the moment that the symptoms begin is key for stroke care. Occasionally, a person may notice the symptoms themselves. For example, a person could wake up and notice that their movement or strength isn't what it was when they went to bed. They might have changes in vision or balance. Other times, someone else is the person noticing that abrupt change in a speech, or if their smile is only on one side of their face, or when they're talking, maybe only one side of their face is moving. That's the moment we call time zero. We want to know when those symptoms started. That's very important in determining what the pathway is going to be for that care. Onset of stroke symptoms, again, we're looking for that spontaneous time that they started, but it's easy to dismiss. Like, how many times do we each have some sort of symptom that we explain or rationalize away because we're tired, or we're dehydrated, or whatever that is. So encouraging people to take those symptoms seriously and realize that they need to be evaluated. It could be a true emergency. So any sudden change in balance, vision, facial symmetry, speech, strength, or sensation, those are indicators of a potential stroke, and they should seek emergency care as soon as possible. We often have patients that will drive themselves or wait for a friend or family member to be available to bring them to the emergency department. But activating 911 is the fastest way to start their stroke care and really reduce that time from when symptoms started to treatment. The first crew to arrive is actually part of our stroke team. Our EMS is trained in stroke care, and they can start it immediately upon meeting the patient, and then deliver them to the rest of the stroke team. Keeping in mind what's going on when a patient might think they're having a stroke. They're scared, they could be apprehensive to seek medical care. Like I mentioned, they might dismiss the signs, the early signs, explain it away. And certainly during other events, for example, the COVID epidemic, we saw a decrease in patients coming to the emergency room with stroke symptoms or chest pain because they were scared and they didn't want to be a burden to a system they thought were already taxed and taking care of this epidemic. And so we actually saw patients experience permanent disability because they were delaying their arrival for care. Fear of the unknown can also result in delaying care. They don't understand what will happen when they get there. They don't want to be dismissed, or even subtle symptoms might make them think that it's not enough to go to the emergency department and be evaluated. But all of these things combine to result in a delay of care, and increase the potential for permanent disability for those patients. Our stroke team receives specialized training. They follow specific protocols to deliver the best care to stroke patients. It really is like a choreographed process. So in the first hour of care, a person will experience a lot of people and have a lot of things going on in a somewhat chaotic environment. It can result in a lot of anxiety for a person experiencing a stroke and their family as well. Emergency department staffs can evaluate and treat a stroke patient. It doesn't have to be a stroke center. It can be a rural emergency department or a small facility, but each location is equipped to identify a stroke and begin initial stroke treatment, and then, if necessary, transfer a patient for continued stroke care. So I want to talk about who makes up the stroke team and the individuals that someone might encounter while seeking out stroke care. Like I mentioned, if they activate 911, the first members of the stroke team that they'll interact with are the first responders. They'll identify symptoms, they'll determine that time zero when symptoms began. Often you'll hear it called the last known well. This is the moment of onset. So in this situation I was describing earlier where a family member might wake up with the symptoms, we really want to go back to when they went to bed. Did they have the symptoms then? And that's the time zero that we'll use when we determine when symptoms started. Like I mentioned, the emergency responders also receive stroke training. They follow protocols that will include using a stroke screening scale. This helps them identify the type of stroke a person is potentially having and where to best take that patient. They might start IVs, draw blood. Certainly they'll take blood pressure measurements and look at heart rhythms. And depending on the severity of the symptoms, a patient might also expect oxygen or breathing support and maybe some medications before they actually get to the hospital. The information that's collected during this first encounter with the stroke team influences where they might take the patient and what type of care they'll deliver. Also, it's important for family members at the scene to provide a contact phone number so that if needed, the stroke team at the hospital can reach out and get more information. If somebody presents directly to the hospital setting in the emergency department, the first members of the stroke team that they'll meet are the triage team. This is usually a nurse. It could also be a nurse practitioner or a physician's assistant, depending on what that emergency department uses for that initial triage encounter. Once it's determined that a patient might be having stroke symptoms, the stroke team convenes at the patient's side. This can be made up of a varied group depending on where you present. It might be a smaller rural hospital where it'll be a nurse and a physician. It could be a stroke center where the stroke team has much deeper staff that'll include a phlebotomist or a radiology technician. Sometimes the neurologist will actually come to the patient's bedside if they're in a facility that has a neurologist on their stroke team. No matter where they present, there's a lot happening at the same time, and it can be overwhelming for the patient. They're getting asked a lot of questions, being given a lot of instructions. There's a lot of things going on in that first 10 to 20 minutes where the stroke team is really trying to establish what's going on with the patient. They'll be sent to imaging. They'll get CAT scans of their brain, and these images and initial lab work will be used to determine the best treatment for them. If it is from bleeding in the brain, the stroke team might also expand to include a neurosurgeon. When the stroke is due to a blood clot, we can often give a medication. So the stroke team might include a pharmacist and a stroke neurologist. And occasionally, depending on where that blood clot is, a neurointerventionalist. So the team gets bigger and bigger as the stroke care goes on, which can be overwhelming to the patient. So next we want to talk about all of these roles and how they combine to create a stroke process and deliver the best care to the patient. And we do have some stroke members on stroke team members on our panel. But as you can imagine, coordinating all this care is a role in and of itself. So we'll also talk about the role of a stroke coordinator. And I want to turn it over to Dr. Richardson to moderate the panel discussion. And Dr. Richardson is also involved in stroke care. She's a stroke researcher. She's a speech language pathologist, and is very active on the in stroke care. Dr. Richardson?
Yes, thank you for sharing, and I'm excited to hear more from you. We did have a question that I wanted to make sure we try to address, and you may not totally have the answer for this. I imagine it's going to be kind of case by case specific, but in the chat, someone said, hey, you know, you're talking about time and the importance of calling 911. I have rural patients. They may be like an hour or more out from the ambulance getting there. What is that recommendation? How do those people get the timely care that they need? Do you have some input into that?
I have a little bit. So when someone calls EMS or activates a medical response system, regardless of where they are, the person on the other end of the phone has specific protocols to follow based on the information that they're collecting. So if, and they are also trained to identify which protocols to use based on what the caller says. So if a caller is saying that they have a loved one that's having difficulty speaking, or, you know, sudden onset of balance changes, whatever they're calling for, they have a set of questions that they will filter down to which protocol to use. And once they identify that stroke protocol, it might include instructions for administering an aspirin during that time frame. They'll ask questions about the patient's breathing and the stability of the patient. And they can actually escalate that from a ground transport to maybe an air transport. Here at Presbyterian, recently we just received a patient from a rural area that dispatcher did end up dispatching a helicopter to the patient's ranch, and the patient was loaded by the flight team and taken here to Presbyterian for their care. So they didn't actually see any rural providers. They were just escalated because of the symptom severity from a ground transport to air transport. So those are all things that dispatcher will take into account when the person calls.
So definitely call and don't administer that aspirin without getting that information first, because if it's not a blockage stroke, that could be disastrous if it's a hemorrhagic. So definitely, I hope, Kimberly, that answered your question, and thank you for sharing that with us, Shana. So I want to share with the folks here about what a stroke coordinator is. There was a whole lot of people that were mentioned on this slide, and so I imagine it's quite a bit of work. So can you tell us just like what is a stroke coordinator, and what's a day in the life of a stroke coordinator? What does that look like for you?
Sure. So the role of the stroke coordinator is really just maintaining the quality of stroke care at a facility. Not every facility or hospital will have a stroke coordinator, but ones that are stroke centers or that have quality processes related to stroke care typically have a stroke coordinator. They'll follow the patient through the continuum of stroke care and monitor how the stroke process works for a patient on an individual basis. They look at things like, does this process meet that patient's needs? Did the stroke team's needs get met? What are their barriers to delivering the best care we can give? How can we remove those barriers? And we also look at what went right and how do we do that and reproduce that process every time. And does it allow us to focus on this patient as an individual and provide for their best outcome? So really the stroke coordinator is more process and support role rather than direct patient care, and helping to facilitate that direct patient care. A typical day really looks different day to day based on the needs of the stroke team. We might have a stroke patient come in that had specific needs that we hadn't encountered before, and don't have that incorporated into our process. And so looking at those sort of things. But basically, I start my day with a case review of our current admissions. I'll look to support the interdisciplinary stroke team as best I can to meet the standards of care for those patients, make sure that they receive diagnostic testing or medications in the most efficient way, and also helping to the staff to deliver education to the patients and their families regarding the type of stroke they have, what rehabilitation might look like, what their next steps will be when they leave the hospital. Coordinating all of that care, like you mentioned, it's can be a lot if you have a big stroke team.
So they may not see you, but they'll definitely see the effects of you.
They may not see me at all. It's kind of in the background.
Gotcha. All right. Well, I'm definitely don't go anywhere. Gonna come back to you. I am going to switch to someone else that you were very helpful in recruiting, and that is a stroke nurse, Thoa. So I'm gonna put the spotlight on you. Hopefully this is working on y'all's end so that I'm spotlighting you. And I just like to know, what is a stroke nurse, to share with the folks here, and what distinguishes a stroke nurse from other types of nurses?
Hi, everyone. Thank you. My name is Thoa, and I've been a stroke nurse at Presbyterian for about 10 years now, and had the privilege of being there when we started the stroke program as well. So a stroke nurse is, we're nurses who are specially trained in stroke care, which is specifically one of the assessments is the NIH assessment, and it's which stands for National Institute of Health, the stroke scale. And so all of the nurses are trained in that scale, and it's just a way to quantify how bad the stroke is. And the higher the score, the worse the disabilities generally are for the patient. The stroke nurse is also trained in what the stroke process is, what our core measures are, and what the best practices are, especially in like what tests and treatments that the patient's need prior to discharge, and especially in what kind of education the patients might need. So what really distinguishes the stroke nurses from other nurses is mostly their assessment skills. With their experience, they can really notice any subtle changes in those patients, because it can be very subtle, and they know how to act in the moment. And they understand the neuroanatomy a little bit better. And so, they understand where the deficits might be and where to go if there was any decline in their status. With strokes, a lot of it, many of the patients may have some dysphagia or become aphasic. And it's almost like learning another language. Being a stroke nurse, you kind of figure out how to talk to those stroke patients and understanding what their needs are. And then dealing with certain disabilities, like they can be very impulsive, and they might not realize what their limitations are, and so it can impact their safety. And so the stroke nurses are really aware of what they are.
Does it require special certification, a special track of continuing education?
There's a certain amount of hours of stroke education that the nurses are required. And like I said, they are required to be certified in the NIH stroke assessment every year. Several of the nurses also have a national certification called the SCRN, which is a stroke certified nurse. And that just enables them to give better care because they understand the neuroanatomy, the processes, and all the treatments. It's not a requirement, but it's good that several of the nurses do have that as well.
Good, thank you. And thank you, Jane, for that question. And thank you, Shana, too, for following up on that. There's someone else who asked about CEs. I'll let Laurel or Sophie follow up on that one. I did have a question then, Thoa. What does a day in your life look like? And I imagine it's going to be different every day. But can you tell us a little bit about your day?
Sure. And, like you said, it is dependent on the patient. If we were getting a patient from the ER, obviously handoff is extremely important, whether they're from the ER or if it's shift to shift. We always do the NIH with the oncoming and the offgoing nurse so that we can compare, because it can be a little bit subjective. And so it's good to have whoever was taking care of the patient prior with the oncoming nurse, so that we know if there were any changes that may have happened in between those times, so that we know, like, are they getting better? Are they getting worse? Is it still the same? So again, doing a good, thorough assessment is extremely important to see where they're improving. And then after that, it's a lot of education for the patient, talking to family, what are their support systems like? And then it's working a lot with the rest of our team. The rehab team is extremely important, PT, OT, and speech, and coordinating, when they can be seen, and just giving them a heads up about the patient. Dietitian is also important, obviously. So just coordinating with the entire stroke team is super important.
Gotcha. So I'm going to pitch this to both Shana and you. If you just had to sum it up really quickly in a couple of sentences, what is the most important aspect of stroke care from your point of view in the first 24 to 48 hours?
I think assessing their baseline is one of the most important. So we see where they are, where they're going to improve. Again, evaluating what their family and support systems are, giving them education on what their specific stroke looks like, and individualizing the education to what their risk factors are, and with the goal of getting them back to their prior level of functioning. But one of the most important also is mobilizing them and having them work with the rehab team and getting them up so that they're improving and not laying in bed.
Gotcha. What about Shana? Do you have anything to add, or you totally agree?
I think that all of those things Thoa mentioned are critical for the first 24 hours in the hospital stay. But for me, from a global perspective, I think the most important thing is to get to care as quickly as possible. And that's kind of my take-home message, is for people to be aware of their stroke risk factors, those of their loved ones. And it really, though, can happen to anyone at any time. And so being able to quickly identify, oh, this could be what's going on, and getting to care, so that the stroke team has the best opportunity for treatment options. And like Thoa said, the goal is always to get them back to the highest level of functioning and quality of life. So.
All right. So I'm going to switch because both of you have mentioned rehab. And so please don't go anywhere, because I want to circle back around and ask everyone some questions. But we have the wonderful honor of having some rehab folks here. So I'm going to transition to Janet. So Janet, could you tell me or tell them a little bit about yourself, and then a little bit about the role of the speech language pathologist or speech therapist in the emergency and acute setting?
Yes. So my name is Janet Adams. I am a speech language pathologist completing her clinical fellowship with Dr. Richardson. We're part of the University of New Mexico's Brain Scouts Research Lab. And I have had some previous work experience at St. Vincent's in the acute setting. So this includes the work with stroke patients and their families. So some things that we do, our role basically impacts many skill areas that are affected after someone's experienced a stroke. One of the more well-known areas is linked to stroke signs and symptoms. I think you guys discussed FAST or BFAST in your last Lunch and Learn meeting. That's where F refers to facial symmetry, S refers to problems with speaking and or understanding speech. So stroke can lead to motor control problems and or sensory disturbances that can impact the ability just to control face and vocal tract functions. So this can involve voice problems, so dysarthria, apraxia of speech, as well as other disorders. And stroke can also affect the ability to produce and understand language, either through speech, reading and writing, or even sign language. And this impact is called aphasia. And so these deficits are also key elements of that test that was mentioned earlier, which is the National Institute of Health Stroke Scale. An SLP will often be involved in administrating or consulting on this test and assessments in those areas. There's also other important skill areas that are impacted that we may assess and refer for treatment. So sensory disturbances that impact the ability to recognize or perceive objects, faces, emotional expressions. It can also impact attention, memory, and other cognitive abilities in a way that also impacts an individual's communication abilities. We're also involved in feeding and swallowing assessments. This is just to make sure that an individual is safe to eat and drink after they've experienced a stroke. In the acute setting, an SLP's role is mostly assessment and consultation and overall patient management. So this is alongside all the other medical professionals. And this is rather than providing direct treatment within this setting. So with the inpatient setting, it's assessments, referrals, and direct treatment for the deficits that I had mentioned previously. So that's kind of our overall role.
So I'm sure that you've heard this before from patients and caregivers and even other professionals, but why does a speech language pathologist evaluate swallowing?
Yeah, this is a very common question because it's obviously not in our title. But this began with a collaboration between the VA neurologist and speech language pathologist back in the 70s. And the neurology team reached out to speech language pathologists who are experts in oral, pharyngeal, and laryngeal components of speech and voice. And their hope was that this expertise could be applied to swallowing, and further hoping that related services could help with the management and successful discharge of people with swallowing problems. So that connection, followed by another paper that was written by a speech language pathologist on dysphagia, which is the swallowing disorder, that was published in 1972. And that's really where things kind of began. A lot of speech language pathologists who work in hospitals are expected to be competent in dysphagia management. And so that's also their expertise include being able to conduct and interpret video fluoroscopy, gosh, that's a hard one, video fluoroscopy examinations to help understand what area within the whole swallowing function is being affected and how to best manage that.
Gotcha. So you also mentioned cognitive evaluation, and I know that OT or occupational therapy is also involved with that. Can you explain the SLP's role in cognitive assessment?
Yeah, so assessing cognitive abilities after a stroke is very important, and depending on the hospital, SLPs and or an occupational therapist are involved in assessing cognition. The SLP is more involved in cognitive deficits that affect communication or swallowing. So some cognitive aspects would be a person's attention, their memory, basic perceptions, and other similar abilities. And so an SLP plays an important role in helping to accurately assess cognition in people with language problems. A lot of the cognitive screens require an individual to have intact language to truly show how those cognitive abilities are being impacted. So if you ask a patient, for example, to name as many different animals as they can think of in 1 minute, and this is supposed to play on a person's cognitive ability to retrieve information from memory, it can be more difficult to assess that in someone who doesn't have intact language, which can be impacted after they've had a stroke. So if you've had aphasia, that type of test would not be valid to administer as a test of true cognition. So that individual would potentially fail it because of the language problems and not so much because of a cognitive impact.
So I imagine there's a lot of coordination, on good interprofessional teams between OT, ST. So let's chat. Thank you, Janet. Let's chat with our occupational therapist who is able to join us. This is Celicia. Can you first address the role of the OT in cognition?
So I would say when we talk about speech, an SLP, and how we transition to an occupational therapist is I like to take all the information that's provided to me in regards to what the SLP looks at, and I like to transition it into function. So the completion of functional tasks, so their ability to sequence, their ability to, so taking that cognitive component and turning it into function is really the basic way of saying it. So can they sequence the steps of making a peanut butter and jelly sandwich? Can they sequence the steps of recalling from memory how to brush their teeth, and then functionally the ability to complete the task? If I ask them to go to a nutrition station, which we might simulate as a kitchen, to make a cup of coffee, do they have that ability to do that? So are they able to functionally complete the task that is being asked of them at that time? And I think that's the most basic way to kind of explain it, is taking all of that information, because cognition is such a huge umbrella and there's so many different things that you can look at, but really translating what we see and then functionally trying to complete those tasks.
Thank you for kind of explaining that link as well. I did not ask you to talk about yourself in terms of where you are. Could you do that quick introduction? I'm sorry.
No, you're fine. My name is Celicia Perez, and I'm an occupational therapist at Downtown Presbyterian.
Thank you. And thank you for joining us again today. Are there other deficits that you treat and assess with stroke, in addition to that, things that are related to cognition?
I do. So I like to say that I take a little bit more of a holistic approach. And when I say the occupational therapists were maybe poorly named, but I'll say the occupation of life to patients, because I'm really looking at what I like to say is the person, the environment, and their occupational, and what they do as occupations, and put all those things together and create a clear holistic picture of what a person needs in order to live their life more fully and be more fulfilled. I like to establish a new baseline of where we are after a stroke so that I can work forward to a new level of independence. And I'd like to assist in returning them to their prior level of function, but always looking at it as what can we do now to help establish where you are, create areas where we can help you the most, that when you go to the next level of care, they can pick up where I left off. So I'm looking at their ability to maybe use one limb over another to feed themselves, to wash their face, to brush their teeth, to comb their hair, to hold their baby or their grandchild, or to play bingo. I mean, there's so many different things that we use, even our hands and our arms for, and our face, our eyes, to do, that play into occupations that we love and that we enjoy on a daily basis. So I'm looking at all those things, as well as the family, to help me initiate good care and education and follow through.
I love that you mentioned that it's poorly named as well, because to me that sounds like a life participation therapist, which is also what, speech language pathologists also identify a lot with. Like we're trying to help you get to communicate so that you can go back to participate in life, or eat, which is also where a lot of our social interactions, are around. So I like that you pointed that out as well. So can you just describe the different settings and time points where you interact with stroke survivors and their families?
So I've interacted with stroke survivors and their families in many different settings. My main setting has been in the hospital, but I've also worked in acute rehab. I've worked in outpatient, and also just in another life, I worked in cardiac rehab. And so I worked with people who had a stroke many years prior and were coming to continue to work out and just try to live a healthier lifestyle to ensure continued forward progression. So I've seen people at every level. And the biggest takeaway that I've learned, that I tell people, is that your relationship with a therapist, whether it be speech, OT, or physical therapy, doesn't end wherever you go to rehab. You can see a therapist and have progression of care for as long as you feel like you need. And so it's just really being able to advocate for those patients at every level of care to ensure that they know that it doesn't just end here. It doesn't just end in rehab. It doesn't just end in home health care. It can go on, and you can continue to move forward and always work on something to be better.
I think that's where we need to work a lot as rehab professionals, and you can let me know if you agree. And Janet, you and also Erin can let me know if you agree. That's where the messaging is still off, because they're still told, oh, wherever you are after a year or two, that's where you're at. No, research tells us something different. Yes, that's where you're going to make most of your progress. Yes, of course, or the quick progress, but recovery can last for a very long time. So that messaging is still not consistent, I think, throughout our healthcare system. Would you agree?
I do agree. I really try to empower families and patients to really advocate for themselves and have this system that we have work for them. And so understanding that every therapist you encounter would love to work with you at any level and will find something to work on, because there's always something to work on, because we want you to be independent, and we want you to have a high quality of life and high level of independence, aging in place, having occupational justice, and ensuring that you're aging in place and you're getting what you need is the most important to us as therapists.
Very well said. Thank you. I'm going to switch, because from some of the things that you said, it seems like there should be a lot of coordination between OT and PT, and we happen to have a PT who's here as well. Erin, can you tell a little bit about yourself and then describe situations where you collaborate with OT? Uh-oh, I'm going to ask you to start your video. Erin, are you there with us today? I can't see you. Having some technical difficulties. I'm going to check back in a moment. Look, we'll go ahead to some questions that I wanted to pitch to everyone, and then hopefully we can come back and hear from Erin after maybe we get some technical difficulties solved. So if I could ask each of you, Celicia and Shana and Janet and Thoa, yes. I think I got everyone. What are some great things or some pros or some just good things that have happened that you've had as an experience of stroke team care to share briefly with us? And so just a couple of sentences to share an experience about the really good things about stroke team care. One of you jump in on that one.
For me, it's really creating a patient-focused team and process, and individualized to the patient and their needs. And I think so far all of the panelists have expressed how important it is for meeting them where they're at and what's the next small step, and just getting to see that progression, and when they are actually able to leave the hospital close to or at their baseline prior to their stroke is just really a rewarding experience to be part of.
Great. Does anyone have anything else to say about that?
As an occupational therapist, I find that it's been really great to, in the moment, working with Thoa, especially because we work together a lot, in the moment, being able to be at bedside and have all of these brains together saying, hey, did you see this? Did you notice this? How can we help this? How can we prevent subluxation from happening? Like in that moment, all of us collaborating together to ensure that our patient is really being well taken care of, and just being able to bounce ideas off of each other and have each other's support and really truly listen to one another and value each person to ensure that our patient does have a positive outcome and does move forward, and not just in the moment, but for moments that will come after that. So like if one positive thing happens, a domino effect of positive things will happen.
I love it. Anyone else have something to add?
I absolutely agree with that. And it is nice. Definitely one of the pros is that we do learn from each other. And, Celicia and I, we've taught a couple classes together. And so it's not just like, this is your role, this is my role. What are we doing together to help this patient improve their quality, their mobility, and help them get where they need to go. So it is completely team nursing, team stroke, right? Team care. So
I love it. Janet, I'm wondering if you could start us off with barriers. Could you share some barriers? I know you probably agree with the pros or the good things.
Yeah, no, those pros are definitely one of the biggest positives of the team is getting to collaborate. And I think some of the barriers that can impact the collaborative nature is just all the time constraints. We really do have kind of short periods of times where we get to interact with these individuals. And so I think being able to meet up with individuals of other occupations is very helpful, but even the time constraints of where everyone is in the hospital can also be a barrier. So positives and also the time can affect it as well. So
does anyone else have a barrier? And Erin, if you can talk now, feel free to jump in, but any barriers to like successfully carrying out stroke team care that kind of persist where you are?
I think a barrier that I can say as an occupational therapist is a limited education on what we all truly do and can bring to the team is a huge one. I think another one is staffing. So when you don't have enough speech therapists, or you don't have enough physical therapists, or you don't have enough occupational therapists, your care has to stop somewhere because you only have so much to give in that moment because you have so many people you need to touch in a day. And so if I had one thing that I could say is I wish that, especially in the hospital setting, SLPs and OTs can do a lot more when it comes to cognition and really play off each other in a really positive way. And so I really wish that we had more freedom to work on some of those things, because I think that we could create something really nice. But the time constraints and staffing and the lack of knowledge of what each one of us does really hinders our ability to be the best we can be sometimes.
So I'm hearing we need more sessions like this is what.
Yes. Running on a loop.
Yeah.
I also, sorry for jumping in. I just want to tag on to what was just said, but some of that also does play in with the billing and insurance barriers for us as well, to not have as close of an interaction as would be the most positive and beneficial for a patient.
For the patient. If you had one thing that you would share with the general public about stroke awareness, stroke prevention, or care, each of you, speed round, what is that one thing? Shana, you first.
Early intervention.
Erin, are you there? Erin, one thing? Celicia.
Understanding that you can always reach out to an occupational therapist. Safety. Aging in place as possible. I mean, there's so many things.
Yeah. We need
just
another session.
Yeah, just knowing we're there.
Thoa.
Stroke recognition, prevention, and early intervention.
Janet.
Yeah, understanding signs and symptoms of stroke. Be fast, be fast, be fast.
And if you had one thing, this is a little deeper, I think, specifically for the patients and the caregivers, what would that be? And we'll start in reverse order. Janet.
We mentioned it a couple times, but I think advocacy is super important, not only for the individuals who had the stroke, but for the people who end up taking care of them. If ask for what you need, because if your health suffers, the care that you provide to the others is also going to suffer. So advocate.
Very well put. Thoa, do you have a message for patients and caregivers?
Sorry, I'm just struggling with my computer. Again, it's the early recognition and the time, and it takes a village. So support, what's your family and your support systems.
Very good. Celicia?
Support groups. So, and caregiver support groups, whether that be in person. I mean, I try to find a bunch and update them often of Albuquerque support groups for caregivers and people who've gone through something traumatic, and it's very hard to find, but I try to find things that are online that I can give them, putting the mask on themselves first. So really support groups and having the ability to really help yourself too, because this is heavy stuff.
Absolutely. And Shana?
I agree with everything that the rest of the panel has said on this, but taking care of your emotional health following a critical situation like a stroke for both the patient and the family, and just realizing that whatever they're feeling is appropriate and okay, and that asking for help is okay.
Well, that's amazing. I wish we had more time. Hopefully we actually have had a meeting about what sessions to have in the future. And one of the sessions that was mentioned was that we should have one that's just on plasticity. So it won't be for this series, but hopefully it'll be for next series. We didn't get to this, but it was such a wonderful interview session. So these links are here for you. And for those people that attended, please make sure that you visit the PowerPoint or the PDF that will be sent to you. Some of this is also in the chat window too. So these are just resources for support, for finding professionals, all of that. So please make sure you visit that. And so I'll let Laurel or Sophie close us out. Sorry for keeping you a little bit, and remind you of what sessions we have going on in the future.
Thank you everyone for attending. Please, I'll put my email in the chat. Let me know if you have any questions following this. And our next session is next Thursday from noon to 1 p.m. Living with a disability after a stroke. So please register, and I'll put my email in the chat. Thanks for being here. It's just really informative, and I'm grateful for everyone that spoke.